Good morning, good afternoon, and good evening, whenever and wherever you are listening. This is an episode of the Two Lost Souls podcast, all about using CBT with long-term health conditions. My name is Ravi Amrath, and as usual, I am joined in the therapy room today by the sensational Michelle Sudbury. How are you doing, Michelle?
Hello, Ravi. I'm really well, thank you. Although my introductions are getting more and more flamboyant. Sensational?
Isn't that what it's always been? What did I use before?
Oh, I don't know. I don't know.
Oh, it was
Maybe it is. I
superb.
don't. I
I
don't.
think it was superb before.
Superb. Sensationals. Maybe pushing it a little bit. I don't know.
That's interesting.
But
Where's
yeah,
that come
thank you.
from?
I don't know. Perhaps I've just been particularly sensational this last week or so. I don't know. Thank you for noticing. If I have, that's appreciated.
No worries.
Yeah.
It's always
How are
it's
you,
always a pleasure
Ravi?
to
You
point it
okay?
out. Yeah, I'm all right. Thank you. I'm not bad.
Good.
Busy time of it at work. It's always interesting. There's some human stuff going on outside of work as well. And it's always interesting trying to find that balance between being a human and being a therapist, right? I don't know about you, but I find that quite a difficult line to tread sometimes.
Mm.
Yeah, it's an interesting
Same
balance to
thing though.
strike.
They're the same thing though, essentially.
What are they? I have a feeling we're going to get quite existential and
Mm.
philosophical about
Yeah,
this.
let's not do that at the beginning. That's probably not a good way to start off, is it?
That'll be way too
Maybe that's
deep.
another episode.
Possibly, if any of you do want to hear an episode on the difference between being a human and being a therapist, please write to us at hello@twolostsouls.co.uk, and we will do our best to arrange that episode. I'll be quite honest, I'm not entirely sure who would be able to get to discuss the difference between being a human and being a therapist. But if
I
any of you
think we
have any
could maybe
ideas,
get Mr. Chat GPT. He might come on as a guest and give us some.
oh, maybe that's a great idea.
Maybe. Let's see what Chat GPT thinks about human and therapist and the
Well, there we
differences between
go.
them.
In that case, let's see how we can get an hour out of that, shall we? We'll try that in the future. Particularly fitting, given our last episode on CBT
Absolutely.
outside the therapy room and CBT with technology as well. We hope you enjoyed that episode. In terms of our episode today, we have the pleasure of being joined by Helen Macdonald, who has so many different roles that I may list them for a while, but to give it an abridged version of what she does, she is a CBT psychotherapist, she is an EMDR therapist, she is a podcast host. Is this her first rival podcast host, possibly?
I think it might be. Yeah, fraternizing with the competition, not
Possibly. I
enemy.
mean, there's no
Competition.
CBT is all about collaboration, though, right? So this is our podcast collaborator rather than competition.
That's lovely. I love that. That's better.
Yeah. And we will be discussing, amongst many things, the role of CBT in treating long-term health conditions, words of advice for trainees who may be encountering cases which do feature an element of long-term health conditions as part of a client's context, and also exploring some systemic issues around our healthcare landscape, how that impacts on the roles that we do. We hope you enjoy this. And without further ado, let's bring in Helen Macdonald. So we have the pleasure of being joined in the therapy room today by Helen Macdonald, who is a CBT therapist, EMDR consultant, lecturer on CBT for long-term health conditions, and a senior clinical advisor for the BABCP. Also podcast host as well. This might be one of the longest CVs we've read out so far. Firstly, welcome to Two Lost Souls podcast. Helen, how are you doing?
Thank you very much, Ravi. It's a pleasure to be here. And yeah, I'm doing okay. As we're speaking, it's my first day back from leave, so I don't know what my inbox has got waiting for me yet. So I'm in a really good mood here.
Ignorance is bliss, as they say.
Absolutely.
First of all, can we start off by, I suppose, recapping your CBT journey, how you ended up getting bitten by the bug of CBT, how this ended up being one of the tools in the toolbox that you use therapeutically?
Well, okay. Well, please take a seat and maybe make a cup of tea, because this will take a little bit of time. I've probably been around in the field since the dinosaurs roamed the earth. So Essentially, after taking a year out, I did a psychology degree, and that's what convinced me that I really wanted to work in mental health. And when I completed my degree, I did a couple of years doing some research on what works to help long stay inpatients in mental health institutions to get back out there and live in the community. This is in the 1980s, and realized very much that what seemed to work were behaviorally grounded techniques, essentially. So that's what got me interested in the field. And I then went and did my psychiatric nurse training and worked for a couple of years, both in the psychiatric hospital and on the community, working with older adults. And then had the opportunity to do nurse behaviour therapist training, which was the nearest you could get to CBT training at that time. Knew that this was my home as soon as I got into the field. And after that training, I set up the first CBT service in West Wales, which is where I was based at the time. And over the years, started to do a little bit of teaching at the University of Swansea on an introductory course in CBT, did some clinical supervision. And at that time, your qualifications to do supervision were very much around, were you qualified? Right, you're already supervising other people, pretty much. I moved to the north of England. I've been based in Sheffield for quite some time. And soon after moving here, I did my master's degree in CBT at the University of Derby and specialised in my research on working with people who've got persistent pain, which has been very much my key area where I specialise. I guess, like any CBT therapist, I've worked a lot with anxiety, depression, and trauma, but I've always had a fascination with long-term conditions. And around the time I finished my master's degree, I had the opportunity to do EMDR training as well. But I would say that my first love, and I don't know, I'm totally infused with CBT as well as enthused by it.
I mean, a really wide-ranging set of experiences there that obviously bring quite a nice variety of different lenses to look through in a therapeutic context. You mentioned there that you've always had a fascination when it comes to persistent pain, long-term conditions. Describe that fascination for me. Why did that hold such an attraction for you?
Well, such a good question. I randomly picked up a book when I was doing my psychology degree, which was called The Puzzle of Pain. And in it, the authors of that book, who were gurus in the field of pain, they're called Melzack and Woyle, really explain the physiology of what we understand about pain and just how much psychological factors make a difference to the impact it has on people. And there was something about that link between the psychological and physical that absolutely got me hooked. And I think just knowing things like what people believe the outcome will be after they've had their first heart attack tends to influence what the outcome is after their first heart attack, all of those kinds of things. And I think also when I had my specialist job in pain management, I think that just showed me the gap between asking the right questions and actually delivering the evidence base. And there was so little provided in the general hospital setting. And it just felt like where I belonged, as well as, I guess, very fundamentally, always having enthusiasm for working with neglected corners of our field.
Got you. And what I'm really hearing there is a refreshing alternative to the medical model, which was prevalent up until that point. And you mentioned the puzzle of pain there. You mentioned beliefs influencing outcomes in terms of client journeys. I suppose starting with that puzzle, all three of us have probably worked with clients who have had long-term health conditions and who are perhaps convinced that it's purely a physical problem and the cure is rooted in the medical model. And I'm curious as to how you begin to explain the place that CBT may have in supporting them to individuals who may hold that belief, particularly given that it sounds incredibly meaningful to you.
Yeah, I suppose depending on the health journey that someone has had before they come to see me, often someone's done quite a tour of different general hospital departments, not always. But by the time you've gone from perhaps seeing the orthopaedic department and the rheumatologists and maybe epidemiology and neurology, and now someone's been told, I want you to see the cognitive behavioural psychotherapist. And sometimes that kind of gives the message that we think it's all in your head because we can't cure it using medical means. And my approach to this is I really want to hear the person's story. I really want to understand where that person is at. And sometimes what I'm doing is saying, if I was in that situation, I'd be feeling really frustrated. I'd be worried. I might feel let down in some situations where people feel that perhaps they've been promised something that didn't deliver, or somebody's kind of, I don't know, it's been kind of implied that this is a psychological problem when actually the physical symptoms are real. And I guess if I can start from properly acknowledging that these symptoms are absolutely real and they have an impact, and what a psychologist, psychotherapist, CBT therapist can do is perhaps help with living life as well as you can despite those symptoms and managing the impact as successfully as possible.
Got you. So what I'm really hearing there is someone offering a significant amount of validation and sort of saying, well, despite the fact that you're seeing a mental health professional right now, that doesn't mean this is all in your head. And what we can do can still not only help understand some of your context, but still try to move us in a direction of living a life that you would like to live. And I'm curious, based on, again, the context in which you operated in this area to start with, I'm wondering if being separate from the medical model kind of took the pressure off a bit, actually, in terms of, I can imagine that when people are doing a tour of the hospital, seeing that plethora of professionals that you spoke about earlier, 5-minute consultations, being really boundaried on what they can and can't speak about. And I can imagine that it was quite liberating for some of the clients you saw to actually have some time to feel heard and understood by someone who still had the same badge on.
It's a really good point. Our privilege as therapists is that we do have time to listen. And I think that 5-minute consultation focused on a very specific physical experience just doesn't allow the healthcare professionals involved to give someone a good listening to. And also whether that consultant or whoever it was that they've seen had training in the right questions to ask. You know, whether somebody's ever even had somebody ask about how do you feel. And so my privilege then is to be able to hear someone's story, and like you use the word validation, and I really hope that that is what I do in my clinical practice and what I help other people coming into this line of work to do, because there's something super important about ensuring that person really does feel heard and that they're seen wherever it is they're at.
I'm thinking a little bit about our more inexperienced therapists who might be coming to work with clients with long-term conditions for the very first time. Actually, what you've just described there, Helen, is a listening ear, a therapist who wants to understand exactly what that experience is like for the person in front of them. And that actually isn't very different to what we do every day in the therapy room, is it? I don't know about you, but I think sometimes I've spoken with perhaps more newly qualified practitioners who have been really anxious about doing something different. And it's just reminding them you're not actually doing anything very different. It's the same compassion, empathy, core conditions that you've always offered to your clients. If you just do that, that might be necessary and sufficient.
I agree with you, Michelle. I mean, for people who are starting out, your CBT training gives you loads of transferable skills. The core conditions, as you've just said, are exactly the same. And I would really want to emphasize that to somebody starting out. You don't have to understand the implications of all the different health conditions that you might see, whether that's the reason for the referral or part of the referral or not. I think sometimes, doing a little bit of homework if you're seeing a condition that you're not familiar with, but we do that if it was a mental health condition that we weren't familiar with as well, either before or after the assessment. And just, what do I need to know? For example, is there a risk issue I might not know about when I'm seeing somebody with this condition, for example? Or is somebody using a term I've just not heard before to describe an experience? It's fine. Go and look it up. Ask the person in front of you to explain it if they can. So you're often learning together. And I would say One of the things about working in long-term health conditions, which is different perhaps from a lot of the people we see in mental health, particularly primary care, is in mental health, primary care, we often expect people to get better. And often the key reason for the referral in long-term conditions, by definition, isn't going to get better, but everything else around it can. And I think those are the things to bear in mind. Loads of transferable skills and set goals that are achievable. Don't try and cure something that we know we can't do, but what's going to improve the quality of life of this person in front of me that they would really like to do.
You used what I thought was an incredibly poignant phrase there of you're often learning together. And I suppose as someone who's lucky enough to have had the training wheels taken off, I'm lucky to be able to approach that phrase with quite a lot of courage. I suppose in my mind, I often envisage a therapeutic journey, often kind of like wandering through the woods with someone else and kind of looking under different rocks and finding out different avenues and exploring as we go to try and find the puzzle pieces to put this together collaboratively. And flipping that on its head somewhat, I can also imagine that for trainees, for therapists without the experience, that phrase of you're often learning together can be quite scary. Actually, I suppose sometimes for the client, that can be really scary, right? In a world where they may have been really well versed in the medical model of I am patient, you are expert, I ask, you give me answer. I'm wondering how you would, I suppose, address taking some of the sting or the scare out of that statement for new trainees.
I think I would start from a position of one of the key pieces of expertise that you have as a trainee or any other stage of your career as a CBT therapist is not being an expert. Your curiosity, your willingness to learn, your transparency in saying, do you know what? I'm really curious to know more about this. I'm also going to discuss it with my clinical supervisor, who is your life raft all the time. Don't underestimate the power of supervision. And it's okay to say to the client, I've got training in this and this and this. This is relatively new to me. So I'm going to make sure that I'm on the right track. And I'm going to, sort of talk to my supervisor. I'm going to do some reading in between now and next time. I think coming with curiosity and humility is actually a really powerful tool that you can use from day one of your training.
I really love that you shared that, Helen. I'm really blessed to get to support lots of trainee CBT therapists, and the desire sometimes to get everything right immediately, do their very best job. And I know I've been in supervisions and my guidance has been, if you don't know, you don't know, and it might be okay to share that and explore it together, to help the client to find their answers, but also, to maybe give you a little bit of enlightenment. And that takes a big step, doesn't it, when you're so desperate to be seen to know what you're doing?
Yeah. And I mean, I think it's also, if I'm not in the business of giving people reassurance when they're anxious, I'm a CBT therapist. I wouldn't dream of doing that. However, one of my favorite pieces of evidence, which really paints me in a poor light, is newly qualified therapists are better at therapy than really experienced ones. So hold on to that. You've got the most up-to-date evidence. You've been taught by great people. You actually know more about what you're doing, and not being overconfident is an advantage. The evidence suggests that I'll be worse at CBT than you are.
I can also imagine that that's also as a result of not having a kind of blueprint, I guess. When you've practiced for so long, you tend to develop almost like an internal database of clients you've had in the past with very similar presenting problems. And you tend to develop this picture of, okay, this is how maybe this should go. It might not, but this is my idea. And so I can imagine that actually an important advantage for a trainee is not knowing everything and using that curiosity as a superpower, essentially. And as we know, CBT is very big on it's okay for you to be human as the therapist too. We are not infallible as individuals. And I'm also wondering if it's quite a helpful thing for you to model what it's like to sit there not knowing something in terms of demonstrating that uncertainty and the fact that you don't need to know everything under the sun for it to be okay.
Yeah, I agree with you, Ravi. I think that, as I said, humility and curiosity, and that another kind of cliche accept that it's a cliche for a reason, is that you want fidelity to the model. You want fidelity to the evidence base with flexibility to that individual. So fidelity with flexibility is a bit of a motto, particularly when it comes to long-term health conditions where we don't necessarily have the tried and tested protocols for all the conditions that we see. For some, there is a bit of a recipe, if you forgive the term, but just really recognizing that, yes, we need to really have a good rationale for doing what we're doing, but it's got to be appropriate to that individual with their own diverse characteristics, their individuality and their history. And as I say, somebody who's newly trained will be more up to date on all of that than I am.
Speaking of flex and fidelity, perhaps on a more systemic level, when we think about the NHS talking therapy services that we work in, it's not uncommon for us to obviously have to sit and do questionnaires with clients, or clients to do questionnaires before they show up for their appointments. And thinking about this from a trainee perspective, as a result of the challenges that people with long-term health conditions face, the bread and butter of the PHQ and the GAD might remain quite stagnant over treatment. And so, first of all, I'm wondering how perhaps a trainee might obtain a better gauge of distance travelled over treatment. And to follow that up, I can resonate with the fact that as a trainee, it's not uncommon to be living outcome measure to outcome measure. Like one week you're going, scores are down, this is great. I'm going really great guns at this. This is going to be a great career path for me. Then the next week, oh no, scores have gone up again. This isn't good. They're not getting better and I'm going to be a rubbish therapist. And so I suppose I'm wondering, in tandem with that first question, how does a trainee therapist avoid that sense of hopelessness that can sometimes creep into something like this?
Oh, what a great question. And I have to say, I mean, having gone on about, sort of being around for a very long time, I would say that I still get imposter syndrome sometimes. So just to be kind of reassuring that feeling doesn't 100% go away. I don't know how reassuring that is. But in terms of measures, there is a really good reason to do the PHQ and the GAD-7. The WASASP, yes, do it. Every single session that the person turns up. However, if you're working with somebody who's got a particular condition, mental health and or long-term condition, if there's a disorder-specific measure, look up how to use it. So some of those measures are great to use. I mean, you'll be familiar with, sort of Penn State Worry Questionnaire, whichever measure you use to screen for PTSD, which I really, really encourage people to do. It's another motto of mine, is have you screened for PTSD when you're working with people with long-term conditions, even more so. But do a disorder-specific measure. Also, there are measures about diabetes distress, chronic obstructive pulmonary disease, the impact of specific conditions. Sometimes those measures are good for start, middle and end. They're not something that shows session by session change. They're not supposed to, because as we've said already, the long-term condition is probably going to be relatively the same in terms of the condition itself. We're not trying to cure that. But it gives you a kind of yardstick of where the person is starting from and makes sure you're measuring changeable things. So, I mean, people who've heard me speak about pain will know that I say, you probably measure everything else except how much pain someone's in. It's not that you don't want to know at the beginning how much pain they say they're in, but focusing somebody's attention on the severity or intensity of the pain is doing just that. It doesn't help you with the things that you're going to try and change. So it's knowing what measures are appropriate and using them either according to the guidance that, the measure itself is supposed to be used for, and making sure that you've got measures of what it is you're actually trying to change.
Got you. And to follow on from that, I was very lucky to be able to do the long-term conditions CBT top-up course at Sheffield University of Sheffield,
University of Sheffield.
University of Sheffield. I do it that way around. And as part of it, obviously, a whole host of really informative content, including information on alternative outcome measures to use. Two other change methody things really stick with me a lot as really key learnings from that time period. And one of them was pacing. The other one was something called a fun prescription. And I don't want to give too many spoiler alerts for the course or for the rest of the curriculum. But I'm wondering if you could perhaps give any of the trainee therapists listening perhaps a bit of a pick and mix of perhaps 2 to 3 tools or change methods that can be really helpful when working with a client who has a long-term health condition.
Well, you've picked a couple of really good ones already, Ravi. I think pacing is one of the key things, in the sense of, I suspect that many of your trainees will already be familiar with using activity scheduling or behavioral activation in terms of monitoring and planning activities. And essentially what pacing does is help people to modify how much and what type of activity to do according to what they are physically able to do without causing a flare up in the symptoms. You know, it's often to do with pain. It might be to do with breathlessness, for example. But in terms of the symptoms that somebody has, it's about managing the energy, managing the activity to get the best possible, the optimum balance, and making sure that when somebody isn't active, they're genuinely resting rather than ruminating about how they ought to be doing something else. So absolutely pacing. And as part of that, you mentioned the fun prescription, which was something I included in our book about pain management. So here's an opportunity for me to plug the incredible self-help book for clients that's called Overcoming Chronic Pain, which is about to come out in its 3rd edition next year. We're just in the process of editing.
So we've
But in
timed that really
there,
well then, Helen.
perfect. Well done. Thank you. I'll pay you later for that one. Thank you. But in there, there's what we called a fun prescription. And the idea there is that part of your therapy is building in rewards. And when somebody's in a position where perhaps they can't look after the household or do as much with their children or do their usual occupation or earn as much because of their long-term condition, the idea of doing rewarding things, having fun can slip off the radar. People can feel that they don't deserve to, or there's no room for it. But actually doing things that are fulfilling, valued, satisfying, and enjoyable, of course, is really key. You know, anybody who's done treatment for depression will be really familiar with this. And so really emphasizing it. We called it a prescription because it's like you're expected to do this. You know, do it 3 times a day and don't discontinue unless your therapist says so. So there's a couple of examples of things that are often really important across the board in different long-term health conditions.
Definitely. I think also to co-plug that book, I think it's also important, particularly alongside the treatment that you offer as a therapist, that might be a really helpful resource to keep the client reflecting, keep the client on that path while outside the therapy room as well. So definitely check that book out. Obviously, 2nd edition is already out, but you might want to wait for the sparkly new 3rd edition that will be out very shortly. I'm also wondering, actually, just based on what you said there when it came to pacing, if I'm correct in remembering, and this might show a huge gap in my knowledge or the fact that my brain is a sieve more than anything else. If I remember correctly from the LTC training, resting doesn't always mean doing nothing. Resting can mean a reduced level of activity. It doesn't need to be sitting in one place. And I suppose also linking that to some of the fun prescription stuff. As you were talking there, I found myself thinking back to school days, funnily enough, where if you were off sick from school, you weren't really allowed to go out anywhere, right? And so I'm wondering how much that's kind of fed into this sort of context that we hold. If I'm ill, then therefore I don't really deserve to do anything.
It's a really good point. And I think a lot of the ways that we respond to being ill are really good in the short term. So if you're acutely unwell, and I often ask this question to people who come on trainings, it's like, what do you do if you're ill? You know, stay in my pajamas all day, watch rubbish TV, let somebody else look after me, you know, call the doctor, really emphasize my poorly voice when I phone work that I can't be there, just to make sure they really understand I'm not well enough to be there, I'm not skiving. All of those things. And I mean, skim over the last one, but they're all really appropriate for an acute illness that's maybe going to last a few days, a couple of weeks. And then I ask the question, what happens if it doesn't get better? And most of those things become actually less helpful if this condition becomes long term. So sitting around in your pajamas all day, watching rubbish telly, actually not the best way to live your life if you're living with a long-term health condition. And so I guess there is a real place for doing things like learning to relax because it can genuinely help reduce the impact of the physical condition, can help you breathe better, it can help your muscles feel looser. All of those things, learning to meditate, doing mindfulness techniques can just make it more possible to be willing to experience the reality that you've actually got in the here and now, and actually has the effect of calming, even though that isn't necessarily the primary reason to do mindfulness meditation. So there's lots of things that you can do when you're not active, as well as looking at, okay, I might not be able to play my favorite sport anymore, but could I do something like yoga or Tai Chi? I may not be able to run up hills anymore, but I can still do landscape painting. I mean, I'm just pulling ideas from real experiences that clients of mine have said. And so getting the balance right between activity and rest so that you're optimizing how much you can do. You're absolutely right. Doesn't mean sitting or lying down and literally doing nothing except potentially thinking negatively about having to lie down and do nothing.
Yeah. Helen, I did my LTC training online. We'd just moved into COVID, and I'd also just taken on a less clinical position in the trust that I was working for. And it coincided with the creation of the long COVID clinics little time afterwards. What you were just saying there about helping clients to explore what is possible for them after undergoing something that hasn't spontaneously gotten better. And I think particularly with long COVID, there was no information about it. Nobody knew what was going to happen, the longevity, the deterioration of the symptoms, or would they improve? And I can recall working with clients who were very hopeless as a result of that, and lots of I can't do this anymore. I can't do this. I can't fish. I can't, socialize, do my hobbies. And I remember having to become much more creative as a therapist in my when I was supporting them. So actually didactic at some points, moving a little bit away from just, being Socratic in my questioning, because actually felt like people were really stuck and just couldn't see alternatives. I suppose my question is it ever okay to support somebody with some creative alternatives to things that perhaps they've loved and enjoyed and can't do anymore? Or should we try and be much more Socratic and help people to come up with their own answers?
Well, again, very good question. And I guess I don't think it's one or the other.
Yeah.
I don't think that it's our job to absolutely avoid ever making a suggestion. I don't think that's necessarily helpful to our clients. I think if we teach our clients how to do problem solving, but we join in with them about, sort of, I don't know, classic problem solving, maybe you start with, okay, this is how you do it. We're going to think of as many uses for a blanket as we can think of. And you do it together, and you try and think of as many possible uses for a blanket that you can possibly think of. And I try to throw in ridiculous ones. I want people to
Yeah.
laugh as
Yes.
part of this, because that gets the creative juices going. So that's one way of getting the creativity going together, by doing something that it's not just Socratic saying, let's do this exercise, but also checking out all the things that they have tried and saying things like, okay, so would your best friend say there is nothing else to try? All of those kind of techniques. But also, it's fine to say, well, actually, there's a disabled people's walking group. I wonder whether you might want the contact details for that. Somebody else I saw who'd had a really similar journey with COVID found that crochet helped. That those sorts of things that you can share, which are making suggestions, but they're not the same as saying you should do this. So it's a balance and a negotiation. It's a collaboration.
I think that advice could be really reassuring. I know you're not in the business of reassurance, Helen, but very reassuring. And I've certainly found myself in positions where I've helped clients to look up, support groups in our local area, or explore their hobbies in a different way. And we've done that together, and it's felt very helpful. Maybe not quite as therapeutic as it as it could be, but very helpful, and what was needed in the moment. And I've got a kind of follow-on question. Something else that I've experienced more as a supervisor is the question of self-disclosure. I remember supporting somebody who was working with a client who had the same condition as them, and there was a lot of dilemma about what to share and how to share it. The argument for sharing was that it could be very supportive to know that I can relate in some respects to what you might be experiencing. And the argument against sharing was that maybe I'm making this about me and my experience. And I'm wondering what your thoughts are on that.
Well, I mean, you've already expressed what some of my thoughts are on that. And you've given me another opportunity to plug. I've been writing a series of articles for CBT Today on ethical dilemmas, and one of them was very much about self-disclosure. And I think for me, if your primary focus is how does this help the client? Am I maintaining my boundaries? And that's the focus. I think there is a certain amount of judicious use of self-disclosure that is genuinely valuable. And I can think of an example. So here's some self-disclosure for your listeners. I have celiac disease, and I have disclosed that to clients, not all of them, where it might have been relevant because it didn't seem to be appropriate to their stage of therapy, what they needed in that moment. Generally, I have found it to be a useful tool to disclose that. But as I say, really in the interests of the client and how that genuinely is going to help them without overstepping my boundaries as a therapist.
Just based on that element of disclosure there, I'm just wondering how having celiac disease perhaps has changed your outlook as a therapist when you treat long-term conditions, actually, and how that formed part of this puzzle for you.
It's a really good question. And one of the really interesting things about this, after all the things that I've said about mostly the people that we're working with, they have long-term conditions where they've had all the right investigations, there is no long-term treatment. I happen to be in the very small group of people who had some really distressing symptoms for a long time, and no one did the right test to find out what the explanation for it was. And once I got diagnosed, something like 80% of my pain went away. So I'd been living with I still do to a certain extent live with persistent pain, but a huge amount of that pain went away when I got diagnosed. I had no idea that the symptoms I was experiencing would have caused, sort of would have been explained by celiac disease. It never occurred to me. But I think, of course, I have empathy for people with long-term conditions. I wouldn't work in this field if I don't. And I think there is something about overtly living with a long-term condition like this that just really helps to weave together those physical, emotional, psychological elements in terms of understanding and validating someone's experience.
I can imagine as well, just as that's a piece of your context, Helen, I can imagine that leads to self-disclosure in a way that's not always explicit, in terms of you not always being in the therapy room and saying, oh, hey, I have celiac too, this is something that I'm managing, but actually just in the way that you communicate, the way that you empathize, the way that you validate. I can imagine that there's actually quite a strong undercurrent there of, I think I have an idea of some of these puzzle pieces that are coming together here, and I understand this.
Yeah, I mean, I guess if you've been through that, is it this, is it that? No, it isn't. All the tests are coming back negative. We better do some more investigations. Try this treatment, even though we don't think it's this disorder. That type of stuff. I actually don't share that part of my journey with my clients. I don't think it's helpful, but I really get it. That sense of, there's something wrong with you. And I started off thinking it was something else. And my GP at the time, I did change my GP, by the way, but my GP at the time said, no, it's not. And essentially went on to do things that implied I was a middle-aged woman. And I was a middle-aged woman. I am a middle-aged woman. And I worked for the NHS. It's stress. It was like, that explained everything. And actually, I believed them. So this is something that I don't necessarily share with a client directly. In fact, I just wouldn't share those aspects of it at all. But that sense of really do believe you, I think has probably got stronger. I'm articulate, I work in health, I've got a 20-year career in the NHS as well as other experiences, and I couldn't get the right kind of thing done. So yeah, I get it.
Yeah. And that being believed, I know, kind of going back to what we started the episode with today, but being believed is crucial, isn't it? I recently read the book that Naga Munchetti wrote from BBC News called It's Probably Nothing, which talks about women and medical symptoms. And what you just described to me there, Helen, as a woman, I feel your pain. Can be a bit of a battle, can't it? And if you feel that you're coming into a therapy room, I'm sure that's also very true for lots of men. I suppose I'm speaking about this from kind of a female perspective because that's the only one I've got. But coming into a therapy room, perhaps because you think I've got to do this because everybody else thinks it's in my head, and now I've got to convince this person in front of me that this is real, it's going to put people off coming to therapy in some instances. It's going to contribute to disengagement, or, you know, those clients that come in and just look at you with suspicion and frustration, and it all comes out in that first session. That's a lot to hold, isn't it? I think.
Absolutely. That sense of I've seen everybody, I've done everything that you've asked, and now you want me to see somebody with psycho on their badge. And,
Yeah.
yeah, absolutely. And it's courageous for the person to have come through the door. And you've just given me an opportunity for my third and final plug.
Go for it.
So, my podcast, when I say mine, it isn't mine. The BABCP's podcast, which I host, called Let's Talk About CBT. One of the things that we've done, the idea is to talk to people who've received CBT and to get the message out there about what CBT might help with and how it might help. And I've been fortunate enough to speak to a lot of lovely, wonderful people who've shared aspects of their experience of CBT with me, including somebody who's got persistent pain, somebody who had a long journey to get diagnosed with Crohn's disease. I've got one coming out soon where I'm talking to a CBT therapist on her experience of menopause and the symptoms that go with that, and being female and just realizing the research that doesn't go into women's specific issues and things like that. So part of what the podcast is for is getting the message out there to people who don't necessarily come through our door, and hopefully helping people to see how it might be of value even when there's a physical condition present.
And I think perhaps an important time for me to send a message out to male trainees or male therapists in terms of maintaining that curiosity. Don't let yourself come across as someone who this needs to be proven to, yet another face in the medical model crowd. Maintain that curiosity and validate and support the information that's coming towards you from the person who has lived it and breathed it for the past however many months or years that they've been on that journey. Also, obviously, please do check out the Let's Talk About CBT podcast. Don't pause this one just yet before you do that. It would be great if you could listen to the end of this one and then move on. I think they partner quite well, so make sure you add it to your rotation list along with ours. Earlier on, when we were speaking about pacing, you used a fantastic phrase of helping clients to explore what is possible. And I'm curious about clients who could have or who have what could be seen as conflicting comorbidities. And so an example that just off the top of my head, fibromyalgia with ADHD, for example, where fibromyalgia wants them to slow down from time to time, but the ADHD needs them moving at 100 miles an hour every second of every day. How does one, I suppose, appreciate the entirety of that? How does one work towards balancing some of those opposing demands and finding what's workable for the person in the room?
Oh, that's a great question. And I do think that our awareness of neurodivergence has massively increased, and the overlap with certain types of long-term condition is poorly understood, but it's getting better, and there are real overlaps. And I think in a situation like that, again, we really start where the client is at and have a look at how much we can balance that. So maybe for some people, we can do so much of a specific activity and then we need to take a break. Maybe for other clients, there needs to be a reminder. There needs to be a challenge. So can you remember to stand up and walk around your desk every 20 minutes? If you need to stay focused on a very specific task, can you actually shift position while staying focused on that task? So I'm standing up at my desk while I'm talking to you. I have a desk that will go down again. I can sit down without actually changing much. You might see the pictures behind me more, that's all. And so again, it's engaging your creativity and the client's creativity and quite likely, I don't want to stereotype people, but somebody with ADHD is likely to be hugely creative in helping you to help them find solutions that work. And it might take some trial and error as well. There's no shame in testing out whether a particular idea will work unless you know it's harmful. If you really do know it's harmful. But testing it out. We're supposed to be helping our clients to use the tools that we use, and being scientific and doing experiments is what we're all about. But I do think sometimes it takes extra care to understand just how difficult certain things are that we're asking people to do. I would say that pacing is one of the most effective and one of the most difficult things that we ask people to do. And being compassionate to myself, getting the client on board with the idea of being kind to themselves as they learn is also a really important skill to bring into that.
I think to include another nugget from the LTC course at this point as well. If I remember correctly, there was quite an important takeaway on grieving in terms of actually acknowledging that you might not be able to do all the things that you were before, but identifying the difference between taking an appropriate amount of time to grieve and acknowledge that loss rather than continuing with either ruminating or the opposite, which would be avoidance and continuing to move at the speed of light all the time.
Yeah, absolutely. I mean, I don't know how you can develop a long-term condition without experiencing some losses, and really genuinely acknowledging the reality of that is an important part. I agree with you. And I don't think that it's helpful for it to get in the way of living a valued life. But living a valued life includes being realistic and being willing to experience the full range of what that's like, which includes loss.
Yeah. Something I use a lot, Helen, as probably Ravi will remember. I'm a big fan of the Lois Tonkins fried egg model of grief. And I've certainly used that with LTC clients before to help them to draw out their new self with their big experience of loss, grief, and their egg white around it. So if you're not familiar with that model, if you're listening, I really encourage you to check it out. It's fantastic. But it's a very visual way to support clients in seeing that actually sometimes that loss is big and it's not going to get smaller, probably, but you can build a life around it. And it's a very collaborative and creative piece of work that you can do together. So I just wanted to kind of do a bit of a shout out to Lois because I think that model is amazing.
I haven't heard it called the fried egg model before, but I'm familiar exactly with those concepts that you've just described. Yeah.
I haven't actually heard that before, Michelle. It's not something that came up back when you were supervising me, but I know that walking away from today, I will be asking my clients to think of as many uses for a blanket as they can and running through the fried egg model as well. Maybe we'll bring in real eggs into the session. That might be quite interesting. Let's take a bit of a break and we will be back in a few short moments. Welcome back to this episode of the Two Lost Souls podcast. Helen, how are you finding your Two Lost Souls experience so far?
Well, I'm absolutely loving it. You're encouraging me to talk about my favourite things about my job. So I'm really enjoying myself here.
Really glad. Do you know what? That's, I think, quite an important thing for established therapists and not only trainees in terms of continuing to pay really good attention to the stuff that's going well and the stuff you really like as part of your role. So I'm really glad that we're doing that today. I'm wondering on a systemic level in terms of long-term health conditions. I suppose with the landscape as it is now, one sadly needn't look too hard to find a sense of upset and despair in terms of how our healthcare system has changed for the worse. And I suppose I'm wondering how that shifting landscape of our healthcare system has changed the narrative and context for people living with long-term health conditions, and whether, as a therapist, being in that difficult position of being within that same system, but tasked with helping heal some of those wounds that this system has caused, how might a therapist approach that pinch point?
Well, you're really making me think. Again, making sure that things that we say and do are very client focused. I really understand that working in the system can be very hard, very demanding, and it can feel as if we're making impossible moral choices about how we focus our time as therapists. And if we really focus on what the experience of the client is and the impact of the experiences they've had, good and bad, of their healthcare journey, let's say, and collaboratively decide what we do that moves them in the direction of a more valued life. We talk about SMART goals, and what's realistic and achievable does have to take into account resources. So I had the experience of being part of a research study, which was very focused on people with long-term conditions who wanted to go back to work when they weren't working. And we had loads of additional funding. So if somebody needed a gym membership, we could just get that for them. If they needed a suit for an interview, we could arrange for that, even driving lessons. And those kind of resources are just not available to people now. The choices that we had as part of that research study are just not realistic. So we have to go with what are the resources that we have, and any campaigning that we do is separate from what happens in the therapy room, however tempting it might be. And as I say, I still feel like we can do an enormously valuable job. And I mean, you've just heard me talk about how you're talking with me about the aspects of my job that I enjoy the most. Enjoyment might not be the right word, strictly speaking, but hugely satisfying when we see people even make the smallest changes that might have a really big impact on outcomes for them. But we also have to take into account the impact that this work has on ourselves and genuinely look after ourselves while navigating those demands that we experience.
I suppose on that as well, Helen, it's not only our clinical population that live with long-term conditions, our therapists do too, right? And I think that's a very timely reminder that you may be dealing with your own very difficult set of circumstances and supporting somebody else through theirs. And a bit of advice, guidance, perhaps, that I kind of like to give to supervisees is, follow your own guidance, look after yourself, think about what's helpful for you to do your job in the best way that you can, and whatever adaptations that might need. So yeah, I was just wondering if you had any thoughts about or tips perhaps for therapists who are also living with LTC.
Well, I guess you've partly answered the question already, in the sense of, yes, take your own advice and believe that it does apply to you. Being kind and compassionate to yourself does apply to you. Doing the best you can to pace does apply to you. And because we're therapists, use your clinical supervision, really use your clinical supervision. And if you're in a position with your clinical supervisor, which can happen, where you don't feel able to be completely open about, for example, signs of burnout, find a trusted colleague that you can talk it over with and make a plan for how to take that forward. Because if we're not well enough to do our job as therapists, we need to take care of ourselves first. Otherwise, we're not doing a good job for our clients, and it isn't fair on them. I totally get it. If I ask a room full of therapists to put their hand up, if they set high standards for themselves and potentially have double standards about how hard they should work and how well they should do compared to everybody else, most hands in the room go up, including mine. So there's a reason we become therapists, for sure, but that doesn't take away our actual responsibility to take care of ourselves as best we can. And I know circumstances are difficult. It doesn't take away that responsibility, though.
There's a running theme on this show where I can't go through a single episode without quoting Dr. Richard Bennett. And I think the relevant quote there is, "You can't give from an empty cup." And I think to add to that, just because you are in a position of supporting others doesn't mean that you yourself don't need support. It's okay for you to be supported by people around you, and you don't need to be a hero. even, to be honest, even in the therapy room, that's not what your job is. You're not there to fix all the problems in the world. In theory, you're not even really there to fix, per se, the client in front of you. And so it's okay for you to take the time to receive some support from the people around you. Perhaps a slightly contentious question around CBT and long-term health conditions. How do you respond to people who assert that treating the impact of long-term health conditions with CBT is basically part of the creeping one-size-fits-allification of CBT?
Well, if someone's coming at this from the perspective of one size fits all, they're not doing CBT, would be my opinion. The whole value of having the evidence base is that we understand things about mechanisms. We understand how people end up in certain types of maintenance cycle. Doesn't explain everything about an individual in front of you because of exactly that. They are an individual. And if we lose sight of that, we need to take a sabbatical at least and really think about carefully what's happened to that. This person in front of me, it's my job to collaborate with them, to understand, develop a shared understanding of what's happening here, and use mine is almost like a coach on a football field. I know how to improve how you play the game, but you're the one playing the game and it's unique to you. So one size fits all is a real shame if people end up believing that that's what CBT is about. I find that really, really sad. And one of the reasons I do the job I do now in trying to get more information out there about what CBT is actually like and what it's supposed to do is to challenge some of the myths around CBT.
I think that's a really great point, Helen. I think it's educating people about CBT, and it is perpetuated by kind of the media, isn't it? I remember there was a bit of a sensationalist headline about menopause now being treated with CBT with absolutely no context. There was no description of how that was going to happen or what that would look like. But the narrative was that just another thing that CBT will fix. And I remember having conversations with therapist colleagues who were, frustrated, baffled, anxious about being asked to fix something else for the population with no training or guidance. And I do feel that we kind of get stuck in those narratives a little bit, don't we?
Yeah. And again, it's another really good example, and actually something that I'm very proud of that we as an organisation in BABCP were able to do was when NICE did a consultation about treatments for menopause, we got people who are experts in CBT and menopause and I pulled together a response to the consultation. NICE changed their guidance because of what we said. And one of the things that we said is that the guidance could be clearer about if somebody's depressed or anxious, then treatment for depression or anxiety is appropriate.
Yeah.
If somebody has symptoms of menopause, CBT doesn't change physiological changes as a result of menopause. It can help people live well with symptoms they're experiencing, but it doesn't replace hormone replacement therapy. Whether or not somebody can have HRT or not, it's not a replacement.
Yeah.
It's good for certain things. And this is the evidence for it. And there are things that are specifically CBT for menopause. It isn't that CBT is good for everybody going through the menopause. It's that there are specific evidence-based things that CBT can do to help with some of the symptoms. So I got quite excited that we were able to get the real expertise and the genuine evidence included and, let's say, help to enhance the NICE guidance to make it clearer what CBT is actually good for in relation to menopause and what it isn't. Because I think sometimes saying what it isn't good for is helpful.
Absolutely.
Otherwise, there's this sense of go for CBT, for everything. Actually, that's not what the evidence tells us. It's good for loads of things. It's brilliant for loads of things. But pretending it's good for stuff it isn't good for is not helpful to anybody.
I'm wondering how much that's potentially down to or indicative of almost a semi-broken bridge between the medical model and what we do, in terms of perhaps people who work in the medical model not really having a firm idea of why we exist, how we treat things, and what the overall plan is. And so I can imagine that there's a lot of referrals in terms of medical health professionals going, well, yeah, maybe they'll be able to deal with this, and messages being misinterpreted or crossed in the meanwhile.
Yeah. And I would say, I mean, I've spent pretty much my entire career in CBT, and the absolute vast majority of everybody who works in the field is dedicated, incredibly well trained, really on board with the evidence base, compassionate, fantastic. And I think the bridge, not just with some of the medical professions, sort of medical model focused medical profession, but also with the general public, is, that kind of really helping people to understand how to tell what they might need for a particular type of difficulty. So more general education about well-being and what genuinely helps your well-being, and how to recognize when you need additional help and what that help might be. And getting the message out there to the general public more, so that, I don't know, I mean, I think there's still a lot of people in the general public, through no fault of their own, who wouldn't know the difference between person-centered counselling, CBT, EMDR, or what specifically you choose each of those approaches for. And I think that perhaps is the next big step that we can take, that helps put people in touch with the therapists who can genuinely help with the difficulties that they're experiencing.
And if it's okay to say it, it probably isn't, Helen, but not just the general public, I find. We have many GPs who don't actually know what it is we do.
Yeah.
They send somebody along for some counselling, whatever that looks like, this kind of catch-all phrase. Maybe there's a place here for the LTC CBT training to be delivered out to our medical colleagues as well. So actually there's a little bit of knowledge about what the hard work that we're doing behind the scenes under this counselling umbrella.
Do you know
Might be
what?
helpful.
I would love nothing more than to have a day with all the trainee medics sometime in their first year. I would love to be able to do a one-day workshop on, just absolute basics of what CBT is about.
Let's
And,
make it happen, Helen. Let's get on the
yeah,
squares. We can do it.
excellent idea. And just, sort of a couple of really straightforward questions that you can always ask that bring you so much. I mean, we talk about the couple of questions based on the PHQ-9 as a screening that a GP can fit into their pathetically short consultations with people.
Yeah.
And I think just having a little bit more understanding would help them. And if we can give GPs some respite, I think all of us do better, quite honestly. And building those connections with the multiple healthcare professionals around us is again, a step that we can, I hope that we can take. So, I mean, I work with a bunch of physiotherapists, which is just a gift. I love working, we've got a couple of other types of healthcare professional in the building, but working with physios, it's marvelous.
And that was the point of LTC training and in IAPT, talking therapies as is now, it was about co-located, patient-centered, coordinated care. That was its remit in its inception. And obviously it was all diluted quite a little bit because of COVID and the logistical nightmare of trying to become co-located. And obviously subsequently, the lack of facilities now within the NHS, particularly in mental health, because they've been redistributed, sold mostly. But that's gold standard, isn't it? That's what I'd like to do. That's where I'd like to be. I'd love to be co-located and working in the oncology clinics, and
and having had the experience of being located in a general hospital in the pain clinic, where an assessment meant you saw the physio, the pain specialist nurse, the consultant anaesthetists, the pain specialists often are anaesthetists, and the psychologist or psychotherapist. That's what your assessment was. And I would love to see that, particularly in departments that see a lot of long-term conditions. Most departments do. I mean, there's a huge number of people who are attending general hospital appointments who would benefit from some really straightforward psychoeducation. So, yeah, I could get on my soapbox for another hour here. So I'm not going to do that. But you can tell I'm really enthusiastic about there are still things that we could do that would enhance our effectiveness and quite likely enhance the efficiency. But change is hard, especially when change is being driven by maybe things that are not the same as that I would want them driven by.
Yeah, it's fascinating that you said the word soapbox there, Helen, because I was literally just preparing to get on my admittedly rather small soapbox, because I think and listeners, feel free to send me angry emails if I'm wrong, but the one thing that I think that was missing for me from this new NHS 10-year plan that was recently released was this sense of system thinking. There was a lot of system thinking in terms of technology and unifying technological systems. And for any listeners out there who are intrigued about careers that combine CBT with technology, we've done an episode with Sven Law on that, so feel free to go back and listen to that. But I think the one thing that was really missing was this logistical systemic thinking in terms of the way we integrate on a day-to-day basis. And earlier on, we spoke about how the shifting sands of the NHS have led to a massive change in the narrative for patients or clients. And I'm wondering also how that has changed multidisciplinary working in terms of considering that, for example, if I want to get in touch with a GP, yeah, I could send them an email. But if I want to get something to them urgently, I'm going to have to join the same telephone queue that all the patients are joining somehow in the 5 minutes that I have to spare between two clients. And so I'm curious as to how that has changed multidisciplinary working for you and how you have navigated some of those changes.
Again, a really good question. And I mean, I've mentioned that I work in a clinic which has got physiotherapists in it and other healthcare professionals. It's a very different setting from primary care talking therapies. And I recognize that. And I think exactly what you're talking about there in terms of how do we communicate between ourselves as professionals is something that could make a big difference. I mean, generally speaking, I do what you do, sort of I write to, email GPs when I need to. But if there's an emergency or a risk issue, it's frustrating. And as healthcare professionals, it just really emphasizes that, the client situation is likely to be even more difficult. I'm no expert on technology. I do think that there are things that technology could do that make these systems more efficient. The models that have been tried for example, how you decide who gets a GP's appointment and how you get one. So there've been different models tried, and what seems to happen mostly at the moment is that the patients feel that they're not getting a good service from it, and it puts pressure on other parts of the system as well. I don't know what the solution is, and I suspect that there will be people with far more technological expertise than I am who'll be able to design models. If we were designing this now, we're not in 1948. If we were designing it now and we wanted good, universal, affordable healthcare, what would we do? And think about how we get from here to there. It would be marvelous. I don't like to be negative in thinking. I'm not certain it's going to happen before I retire.
Okay. We ask our listeners to write into us at hello@twolostsouls.co.uk with any questions they have for any upcoming episodes, any topics for upcoming episodes that they would like to hear, and join us potentially for a segment that we like to call Socratic Questions. So this question comes from Chelsea. Chelsea says, "Hi, Shell, Ravi and Helen. I hope you're well and having a good day. I just wanted to say thank you for doing the Two Lost Souls podcast. It was a great support throughout my training year, which I just found out that I passed. Woo! Your podcast was a great help, both practically and emotionally. I was wondering if you could do an episode on health anxiety with a long-term health condition. I struggle with the thoughts and belief side of the formulation and navigating understandable maintenance factors, given the experience that the clients have had in the past." Thanks again, and look forward to hearing some new episodes soon. So, Helen, any thoughts on balancing long-term conditions with a presentation of health anxiety?
Yes, I do. Can I first say, though, congratulations, Chelsea. Welcome to the team. Well done. You survived it. It's fantastic. Brilliant. Okay, tricky question. It's a really good one. And I think to me, navigating it is about really looking carefully at the formulation of, is this person using judicious safety behaviours, for example? Is their anxiety functional? Is it helping them? For example, is there help seeking behaviour which is proportional to the long term health condition? So, what you're doing essentially is navigating which behaviours genuinely help this person to move in the direction of a valued life. And are there things that get in the way of that? So, for example, very commonly checking, reassurance seeking to an excessive level. One of the ways of going about this, and I have to thank my friend and colleague Paul Salkowskis for this, is having a look at, if you had these symptoms but you weren't worried about them, would your GP worry about them? So one of the things you can do is actually do the experiment of asking, going to your next GP appointment, which you've probably got if you have a long-term health condition and health anxiety, and say, if I have a new symptom, which are the ones I should worry about? If I've got an existing symptom, which seems to have got worse, at what point do I seek additional help for it? So that you've got a genuine guideline about what's an appropriate concern and what's unhelpful worry.
Again, I think we're back into the realm of context, really, aren't we? Just as a kind of reflection from clients that I've had in the same vein, there's a big difference between certain behaviours that move the client in the right direction of treating and managing that health condition. For example, attending their routinely scheduled medical appointments, and some stuff that just gives them the reassurance or belief that everything is going to be fine. So, for example, touching wood, counting magpies, doing those things that some clients can do to just give them that sense of things feeling a bit more comfortable in the moment.
Just to say that somebody with health anxiety is not exempt from developing a new condition.
Yeah.
So when you see somebody, whether or not they've got existing long-term health conditions or not, and they do have health anxiety, that doesn't mean they haven't also got a physical health condition or developed one. And I just think our ability to be humble and curious allows us never to say, you have not got X. And really being very cautious about saying anything that implies there is nothing wrong. And I've seen a huge number of clients during my career, and I can think of two where this was an issue. And in one case, it turned out the person already had quite a serious health condition that hadn't been picked up. And in another situation where they developed one while they were in treatment for health anxiety. And it's just having that humility to, is this anxiety functional? Is it an appropriate response, appropriate health seeking for the symptoms that they're experiencing?
I think to add to that as well, I'm conscious that this isn't an episode on health anxiety, but as Dr. Geraldine Fletcher told me when I was doing my CBT training at University of Birmingham, when we treat health anxiety, we're not reducing the likelihood of someone developing health conditions. We're reducing the likelihood of them feeling anxious about developing the health conditions. The health conditions still might happen. They might be there. And in many cases, given that our brain is wired for survival, it makes sense that we're going to be vigilant at points, but what we don't want to do is carry an excessively heavy amount of worry that's going to end up pulling us away from a life that we would like to live.
And
Yeah,
I
absolutely.
suppose just kind of on top of that as well, the other thing that we're doing when we're working with long-term health conditions and health anxiety is helping people to recognize their own ability to cope and endure, not just, maybe not always thrive, but coping with what's already there, and that kind of is transferable across the two as well, isn't it?
Yeah, very much so. Yeah.
Yeah.
Thank you very much, Chelsea, for sending that question in. Again, if anyone would like to send any further questions to us, our email address is hello@twolostsouls.co.uk. As I've mentioned on previous episodes, there is a Twitter/X/whatever we're calling it this week profile out there. We don't check it that often anymore because it's not the same as it used to be, that place. But you still might potentially be able to reach us on there if you do have any questions. But hello@twolostsouls.co.uk is the preferred avenue. Helen, thank you so much for joining us today. Before we wrap things up, where can people find out more about you, the work you do, podcasts, books, anything else? Where might people be able to find all of that information?
Okay, well, thank you. Firstly, if you want to know more about the podcasts, it's Let's Talk About CBT. There are, in fact, 4 streams to it now. So there's the one I've spoken about, which is about me speaking with people who've received CBT and sometimes with therapists as well. But essentially, the focus is on members of the public hearing about CBT. There's also my lovely colleague, Rachel Handley, who does the Let's Talk About CBT Practice Matters podcast, which might be super useful for people who are recently trained, where she really talks to experts about specific techniques and treatments in CBT. So really brings out the detail of how to do it well. And then there's also my other lovely colleague, Steph Kerno, who's our journal's managing editor. And she does the Research Matters podcast, where she talks to people who are doing the research about doing, sort of about why they were interested in that topic, how they went about it, and why it's their passion. And she's also done some work on really promoting people getting involved in doing research. Being a full-time clinician, it can be hard to fit in, but, tips and tricks on getting research active and getting things published. We've also got the new one. I hope that all the people listening to your podcast are BABCP members. And we have our Members Matters, which is more like a magazine where we introduce people from our committees, special interest groups, local branches, members of staff, people on the board. So you get to meet people who are part of BABCP and also talk about what's happening, news, events coming up and so on. And in amongst all that, Let's Talk About CBT stuff, we're really thinking of doing a bit of a mini series, which is for trainees. So I'm hoping to invite you two to come and talk to me as part of that. And we'll talk separately about doing that. But it would be an absolute pleasure to have you return the favour and be interviewed by me about what you do and about the experience of being a trainee. Other things I do, if you look up Senior Clinical Advisor on the BABCP website, you'll find something about my role and who I am. And outside BABCP, as you're aware, I teach on the long-term conditions course at the University of Sheffield and do some clinical work as well and some clinical supervision. I think I can safely say I never get bored.
As you were talking, though, I just couldn't figure out how there were so many hours in a day, to be honest, Helen. In terms of the LTC course and pathways, etc., am I right in thinking that it is a mandatory component that people have to complete after they've done their high intensity training? Is that correct?
Essentially, if you work for the NHS Talking Therapist Service in England, you're expected to do the long-term conditions training. It's a 5-day training for wellbeing practitioners, a 10-day training for high-intensity therapists. You're expected to be registered or accredited to do the training. That's what we expect of people attending. Most people who've done the course have found it incredibly rewarding. Yes, it's hard work, but a lot of people have said it's really enhanced their practice across the board, as well as specifically with people who've got long-term conditions. And just having the space to spend 10 days learning and reflecting on how and why we do what we do is a real privilege when we're in the world of frantic talking therapist work.
It's not often that we get the chance to break up our clinical days, and it's nice to have that kind of back to school feeling sometimes. So definitely recommend that course. It is a fantastic set of tools to add to an already established toolbox, which I think is really useful. Thank you for your time today, Helen, and thank you for everything
Thank you.
you've shared today. We would love to have you back on at some point, and we would of course love to be on your show at some point too.
Absolutely.
Thank you for coming on today, and we look forward to speaking with you soon.
Thank you so much, both of you. It's been a real pleasure to talk to you both. Thank you for inviting me. And yes, absolutely, I will come back one day.
Fantastic.
Yay.
Thank you.
Ravi, you tell me off because I always say the same thing, but oh my goodness, I'm absolutely in love with Helen. I thought that was brilliant. I really enjoyed that episode. I think the subject matter, firstly, is just so important, isn't it? Long-term health conditions. We've got so many of our population who are living with physical health, mental health, that comorbidity, and Helen's words kind of really helped me to feel more equipped and able to support people who are quite distressed or living in pain. I loved it. Really, really enjoyed her reflections and just her whole approach to helping people to live their best lives. Love that. I think as a more experienced CBT therapist, she offered me a lot, and I really believe our trainees who listen to this will take an awful lot away from that episode. Great. Really enjoyed it.
Definitely. I suppose I'm wondering, in terms of operationalizing some of that, what are the things, either as a therapist or a supervisor, that you think you're going to implement in response to some of this?
That's a brilliant question. You know, one of the things that's on my mind at the moment in terms of long-term health conditions is I really want to start to use our mindfulness teachers, myself included, that we have in our service now to support people who live with chronic pain. I think there's an awful lot of evidence. And what I found very empowering today was Helen's reflections on, firstly, that fidelity to the model, reminding us that that's still incredibly important and valuable, but also the flex. I loved that. And it really brought to mind helping people who often are feeling a great sense of loss, as you kind of highlighted. Life won't ever be the same for many people as it may have been prior to their diagnosis or the development of their condition, and helping them to have a new normal, but one that feels like a value driven life. And I really feel that there's a place for mindfulness in that. And I think I feel a bit more empowered and very enthused today to kind of go back to my service and start to explore that with a bit more gusto, because it's been a bit dormant. It's been rumbling away at the back of my mind, but pushed down that priorities list by lots of other operational tasks. So that's where I am. That's where I'm leaving this
I
today.
think that sounds incredibly heartening and inspirational, because I suppose to me that embodies a lot of what was conveyed during the interview today, in terms of maintaining that curiosity, maintaining that view that there are still things that perhaps we can do better in terms of reflection, and us not being the finished product, I guess, as therapists. And I think quite an important theme that listeners may have noticed over the past few episodes, I think, is interviewees coming onto this show and really crusading for creativity. And again, I don't want this to sound overly twee or overly repetitive, having had similar takeaways from previous episodes, but don't be afraid to be curious and be creative with what you do. I think I'm going to get on my mini soapbox again here. As a trainee, you can often find yourself going into CBT training with the obsession of getting it right and doing things 100% the right way. In some circumstances, right doesn't exist, particularly in terms of the way that we can be creative with some of these tools that we use. I've always been of the opinion that you can gather 18 therapists in a room, and they might get you to the same point on the map, but they might get you there in 18 dramatically different ways. And sometimes that's the beauty of what we do. This is a people business, and sometimes that can be messy. People don't always click, right? But sometimes the fact that we have that human connection and that unique variability can be one of the most beautiful things that we can be a part of when we are engaged in this role.
That.
Yeah.
It's a great description of what we do every day.
Yeah. Wouldn't it be great if I was this Deepak Chopra like in every element of my life? So spoiler alert to listeners
No.
there, I am definitely not. But that's my unique difference, I guess, and the way I
Yeah.
approach some of this stuff. But before I rabbit on for too long, just a reminder to you all listening out there to get in touch with us. hello@twolostsouls.co.uk. Sign up to the mailing list at www.twolostsouls.co.uk. Thank you to everyone who has signed up so far. It really means a huge amount to us to be
Mm.
building this community and to be having some closer knit connections with you all. Like social media nowadays, you can't really guarantee whether the message is really getting out there due to the power of the almighty algorithm. So to actually have some direct contact with you is incredibly heartening, and thank you very much to everyone who signed up. To those who haven't, please do. We've got some great episodes coming up on children and young people's IAPT. We've got episodes on burnout. We are planning some episodes on the difference between working as a high intensity CBT therapist and a clinical psychologist, and also an episode on developing therapeutic materials as well. We're really looking forward to all of these. We hope you are too. If there are any things that you'd like us to discuss on the show, again, hello@twolostsouls.co.uk. All that's left for us to do is say a big thank you to you for listening. We hope you have a lovely time, whatever it is that you're doing, and we will catch you some point soon for the next episode of the Two Lost Souls podcast.